Welcome to our Future of Healthcare virtual event on improving postpartum care. I'm Paige Hopkins, Axios' social host and on air talent, and I'm coming to you today from DC. Welcome to our audiences on Facebook, YouTube, X, LinkedIn, and on Axios.com. Join the conversation today on X with @Axios and hashtag Axios events. Over the next 40 minutes, I'll be joined by my colleague Tina Reed, and we'll go deeper into the policies and most effective practices to improve access to postpartum and maternal mental health care and health outcomes. I'm excited to welcome our first guest today. She's a co-chair of the Bipartisan Maternity Care Caucus, Illinois Congresswoman Robin Kelly, joining from Washington, D.C. Congresswoman, thank you for joining us.
Thank you for having me.
Of course, this will be a good conversation. As you know, as we all know, we are fresh off of a grueling election cycle. And I've seen a lot, maybe you've seen this too, from young women, particularly young women of color, who are seriously reconsidering whether they want to have children as they anticipate impacts from the incoming administration. I'm wondering what anticipated impacts you're expecting and what you would say to women who are having to think about their future family planning based on who's in the White House.
Sure. Well, a lot goes into whether you should have a child or not, no matter who's in the White House. It just depends on your circumstance. But as a mom of two, I can imagine that it's very scary for people that have not had children yet because of um, the rhetoric that we've heard during the election, Trump's Project 2025, the things that they want to roll back, what happened with the Supreme Court with Roe v. Wade. If you do get pregnant and it's a troubled pregnancy, or your child's not going to make it because of an ailment or a disease or something that they have, I imagine it's scary for women to want to take that chance. But I do expect things that I would consider very negative when you think about the rhetoric of rolling back, Medicaid and, states that put in place immediately restrictions on abortion when there was no more Roe v. Wade.
Something you mentioned that there are a lot of different factors when it comes to deciding whether or not having a child, and that is true. And something I know that you've talked about recently and introduced legislation around is rural healthcare, and I suspect that that's maybe one of the things people take into consideration when they're doing family planning. I'm wondering, from your constituents or from others you've spoken to, what are some of the biggest obstacles facing new moms specifically who live in rural parts of the country?
Sure. As you might know, my district is urban, suburban, and rural, and I have 4,500 farms in my district. And when I first started serving in this district, I had a town that had one OBGYN of a town of 30,000. So the things that I hear from some of my farmers and other people is just the lack of access, that you have to drive so far. One farmer told me the story of driving 60 miles for his wife to have a baby. But I think lack of access is a major, major factor for people that live in rural areas. So many counties don't even have places where women can deliver their babies. So if you're talking about rolling back and not having, the support that is necessary, that's a problem. And that's why we have the legislation to try to give more resources, more access to women that live in those areas.
Are you concerned at all about getting some of this legislation through as we see the changes with the House, with the Senate, and again with the administration? How are you anticipating pushing some of these changes that you're advocating for with some new colleagues?
I am concerned. I'm not going to say that I'm not, but we have passed legislation before. I've been in Congress 11 and a half years and only 4 years in the majority. So we have gotten pieces of legislation passed in a bipartisan way. And as you said, I am co-chair of the Bipartisan Maternal Health Caucus. So I'm hoping my Republican co-chair will help. I know she has concerns about women being able to have babies in a safe manner. So hopefully she and others will join in. We're losing some of the doctors on the Republican side that we work with, but it's about, talking to people, building relations, also them hearing from women and families that they represent, I feel will help also.
As you know, as I know, Black women and women of color are disproportionately impacted when it comes to many of the issues surrounding maternal health and specifically maternal mortality. Your Care for Moms Act specifically calls for diversifying the doula workforce. So I was hoping we could talk a little bit about doulas, and I'm interested to hear from you. How do doulas fit here in terms of keeping moms safe and also supporting them after they give birth?
Well, when I served on the oversight committee, we actually had a hearing, and Tatiana Ali spoke and other women, and they talked about the first time they didn't have a doula, and then the second time they did, and how much smoother their pregnancy was, before, during, and after, that you had someone dedicated to you, looking out for you and your baby's interests. So I think doulas can play a very important role in helping women get through their pregnancies, and we would like to see that workforce uplifted. And of course, it's always a plus when it's a diverse workforce.
Sure. Um, there are many folks who are advocating for time off, more time off for moms and new parents, and also for the non-birthing partner. Can you talk about any efforts you're working on, or that you're aware that your colleagues are working on to get more time off for families? Because I think that's something that a lot of people advocate for, specifically in thinking of postpartum care and kind of getting mom and baby healthy after that event.
Sure. Well, we were the leaders actually in getting postpartum coverage from 60 days to a year with Medicaid. And I so pleased myself because 47 states have bought into that. So I do think postpartum care is very important. Even in my own office, we've given the dads off so they could be there with their wife or partner and their new baby. So I think it's extremely important. And we really, we need to look at the facts and the science and, what OBGYNs recommend and pediatricians recommend. We don't make the decisions or the legislation we write in a vacuum. We really go to the source and also to, the moms and dad to see what will be helpful.
Sure. Another big issue in this area is the cost of childcare. I am a parent and I spend so much money every month on childcare. And I'm wondering a similar question. What can you do? What are your colleagues working on in terms of lowering the cost of childcare so that it's not quite so expensive for new parents and for all parents to work while having a safe place to have their child during the day?
Sure. You spoke about what concerns me, and that's something in um, Trump's Project 2025. There's no improvement in access to childcare. And first of all, we need more places where parents can bring their children, and also we need to pay childcare workers more. I did it myself when I graduated, my last year in college. And when I graduated, that was my first job out of college. It's a hard job. It's an important job. And if we want parents to feel like they can go to work and give back to society and that kind of thing, we have to help them, with childcare. And I know we've looked at different pieces of legislation or, appropriations and things like that. But again, as we move into this new administration, I just don't know what the fate of that'll be, at least for now.
Well, we'll certainly keep an eye out on your work and your efforts and the efforts of your colleagues as well. We're wrapping up, but I want to end on something that I know that you are passionate about, which is a healthcare topic that impacts new moms and everyone else. Food is medicine. Can you talk about some of your efforts around making sure that there are healthy, fresh fruits and vegetables and foods for all Americans to access?
Sure. When I became the chair of the Congressional Black Caucus, it really Health Brain Trust. It really opened my eyes to the part food plays, and obesity and not healthy food. And depending on where you live, you could get a hamburger before you could get an apple. And even if you could get an apple or a banana, it was so much more money. So we have our bill, Food is Medicine, to really work in that this is a part of our health. This is something we need to work with doctors for. This is something we need to make sure that moms, when they are pregnant and when they have their babies, that they have better access to in an affordable way. So we hope to see grants and different things like that in working with our doctors and nutritionists and dietitians.
Wonderful. Well, that's something we'll be checking for as well. Unfortunately, we'll have to leave it there. Representative Kelly, thank you so much for joining us.
Thank you so much, and happy holidays.
Happy holidays to you. And next, a patient story from our sponsor.
Postpartum depression was, I don't even know that it's a term I'd ever really even heard or given any thought to. I vaguely remember when she first became pregnant, somebody saying, hey, you better watch out for those baby blues. And I think that's probably the term that I was more familiar with. You know, Alexis wasn't the girl that this happens to. We weren't the couple that this happens to. And we just had this fairy tale pregnancy. She never got sick. I mean, it was like seamless. It was perfect. And it was extra hard after Adriana came because everything else up till that point was so easy. It just started like this 2.5 week spiral that it was hard to imagine someone could get that sick that quick. And to see someone that was always so together fall so apart, and every day just worse than the previous, and it just anti-anxiety medication, sleeping pills, nothing worked. She looked at me and she said, nobody cares about people like me. Nobody's gonna help me. And it's so disgusting and so shameful for me to be here today. The ball was dropped so many times, it is sickening. We're making strides and we're moving in the right direction. There's facilities across the United States today that there were none 10 years ago. There's new medicines, there's new technologies. People are starting to get it. And so, that's really my hope with all of this, is that this is a big step to push the needle further. It feels good to be a part of the change.
Good afternoon, and thank you for joining us. I'm Chris Freites. A big thank you to our sponsor, the Policy Center for Maternal Mental Health, for sharing that important patient video and making this conversation possible. Joining me now from the Policy Center for Maternal Mental Health is its CEO, Joy Burkhard. Joy, thank you so much for joining Axios.
Thank you so much, Chris. It's great to be here.
So, Joy, as we just heard, the lack of postpartum care can have tragic outcomes for patients. I wonder, what do we know about preventable maternal deaths?
Yeah, this is such an important question. And unfortunately, Stephen and Alexis's story is far too common in America. Over 800 women die due to conditions related to childbirth in the US each year. This is referred to as maternal mortality. The US, unfortunately, has a rate of maternal mortality that's much higher than all other developed nations in the world. What people often assume is that mothers are primarily dying during labor and delivery. And of course, while too many women are dying during this time, the majority of maternal deaths actually happen in the postpartum period. The CDC, using information from the states, has noted that 80% of maternal deaths are preventable. As someone with over 25 years leading healthcare quality improvement and compliance initiatives, it's become clear that the primary reason for these preventable maternal deaths is lack of infrastructure, such as safety standards and monitoring of maternal health and maternal health care in America. And an analogy I like to use is a comparison to commercial aviation. In 2022, there were just over 800 maternal deaths in the United States. By contrast, there were 0 deaths related to commercial airlines or plane crashes in 2022. And so it makes you pause and think, what's the difference and what's happening with aviation? And as we all know, the federal government sets standards and has a process for monitoring safety, including a federal agency, the FAA, which we've all heard about before, that monitors air traffic and inspecting airplanes. There's congressional briefings that involve the FAA and others accountable for safety in commercial airlines. So much more focus on infrastructure and safety and monitoring. And this infrastructure could go a long way in improving maternal health and postpartum care in America.
So, Joy, what are we learning about maternal mental health and suicides?
Yep. So it's a great question. Important to understand where this sits within the realm of maternal mortality. And maternal mental health conditions are the leading cause of maternal death in the United States. And we like to frame maternal mental health in what we call 4 key points, or maternal mental health by the 20s. So I'm going to read these statements briefly. 20% of those who are pregnant or in the postpartum period will suffer from a maternal mental health disorder like postpartum depression. Less than 20% are screened for maternal mental health disorders to detect them. Interestingly, Medicaid population is screened at higher rates than the privately insured patients, in part because there's more infrastructure in place through the Medicaid program. Less than 20% of those who suffer from a maternal mental health disorder receive treatment, and roughly 20% of maternal deaths are due to suicide. So just quickly, 20% of those who are pregnant or in the postpartum period will suffer from maternal mental health disorder. Less than 20% are screened to detect these disorders. Less than 20% who suffer will receive treatment to get well. And 20% of maternal deaths are due to suicide. So there's a great opportunity for the future health of our families here in the United States to change these results and change them as quickly as possible.
Right, and you mentioned one of the ways to do that is for the federal government to get involved. You compared it to aviation guidelines, and I wonder, what are doctors and the federal regulators doing to develop these postpartum and maternal health guidelines?
Yeah. Thanks, Chris. And as you mentioned, we've already discussed guidelines and safety standards, for example. They're in a really important step in the right direction to improving postpartum care and maternal health in America. With regard to postpartum care specifically, the American College of Obstetricians and Gynecologists, known as ACOG, has long recognized that postpartum care should not be limited to just one visit in the postpartum period, which is currently all that most insurers and most Medicaid agencies are paying for. Specifically, ACOG says to optimize the health of women and infants and families, postpartum care should become an ongoing process rather than a single encounter, with services and supports tailored to each woman's individual needs throughout the postpartum period. I also wanted to share that ACOG has issued the first clinical practice guidelines specific to maternal mental health care to address detection and treatment, and defines that screening should happen to detect these disorders throughout the postpartum period and multiple times. Also, Congress, through a piece of federal legislation signed by President Trump, but enacted and set up this year by the current administration, has run a federal maternal mental health task force that has issued recommendations this year, and comprehensive recommendations about the need for postpartum care and supports throughout the full postpartum period.
So, after those kinds of screenings, what kinds of treatments are available for postpartum depression? And what do providers need to ensure that they can successfully treat these disorders? And importantly, that patients can get access to those treatments?
Yep. There's a range of evidence-based treatments and supports for maternal mental health conditions. We have a menu of options on our website, including natural treatments, for things like nutrition adjustments and exercise, but also, of course, very importantly, counseling and medications are treatments that can be very, very effective. Counseling provided by perinatal mental health certified providers is the gold standard, and medications like antidepressants can also help. However, sometimes these medications can take weeks and sometimes months to work. And there's a new FDA-approved treatment specific to postpartum depression, which we think is really life-saving and life-changing for families that are suffering. It's called Zurzuvae, and it works within days instead of weeks or months. We published a report just this week to address how insurance coverage is being handled for this treatment, and the majority of health insurers and Medicaid plans, thankfully, are covering these treatments. It's also important to look at services like certified peer support specialists, access to doulas and OBGYNs and midwives throughout the postpartum period.
All right, well, we have to leave it there. We are out of time. Joy Burkhardt is the CEO of the Policy Center for Maternal Mental Health. Joy, thank you so much for joining Axios.
Thank you, Chris.
And now, over to Tina Reed.
Thanks, Chris. Our next guest is the founder and CEO of Maven Clinic, Kate Ryder. Thank you so much for being here today, Kate.
Thanks so much for having me.
So as we continue our conversation about maternal mortality, I'd really like to hear a little bit about what your experience has been with your own company, of what you've seen with this trend playing out in the U.S.
Sure. So I started Maven about 10 years ago, and what we do is we're the largest virtual clinic in women's and family health. We cover fertility, maternity, pediatrics, and menopause, but we really started in maternity care and postpartum care 10 years ago. 10 years ago, postpartum care, no one was really talking about it at all. So whether it was postpartum depression and instances of that and the lack of screening, to women going back to work, to maternal death and maternal mortality, and what that was like in a lot of the Medicaid populations. I think now we're finally starting to talk about it, but the issue is that it hasn't, there hasn't been as much progress as we would like to see. More than 50% of maternal deaths in the postpartum period are preventable. And so I think that particularly as we go into the kind of next few years, it's just so important to always have that level of transparency and data and inquisitive as to why, so that we can have that conversation and really start to turn the tide.
And when we think about industry-wide and just what women are encountering, where do we tend to see the biggest gaps in care?
Well, specifically in maternal health and postpartum, a lot of the gaps in care, particularly in Medicaid, were around coverage. So, for a really long time, and when I started Maven, a lot of women lost coverage 6 weeks after having a baby in Medicaid. That's gotten better. A lot of states have expanded Medicaid coverage of new moms, but it's still very uneven, and that's where a lot of the preventable deaths occur. I think that from a screening standpoint as well, maternal mental health, this is where it really hits a lot. And so we've gotten, again, better on screening certainly in the last 10 years, but there's still a lot more room. I think that particularly in postpartum depression, it doesn't just necessarily hit right when you leave the hospital. There's multiple moments it can hit. And so continuing to actively monitor that. At Maven, we see 90% of our members taking our screenings for maternal mental health, and we're seeing, upwards of 35% of our members using our maternal mental health services. So there is a real need here. I think the other thing that we're really interested in from a postpartum and maternal health care standpoint in terms of filling gaps is expanding the workforce. Right now, there's a lot of maternity care deserts in the U.S. More than 35% of U.S. counties don't have an OBGYN, and particularly with different states and the unevenness of policies there, those care deserts are getting worse. And so you not only have those care deserts, but then when it comes to, for example, doulas, which support during birth, providers who support during birth, or the expansion of midwives, this is also really important to turning the tide and improving underlying outcomes.
You talked about a topic we've been covering quite a bit, which is this, we are seeing in certain areas with changing policies, we're getting more of these maternity care deserts, and also just the economics of maternity wards, for instance, have not been great. So a lot of hospitals have been closing them. When we think about, though, the policy environment, when we think about how some states have been putting more strict abortion bans in place. How is Maven navigating this environment in which, pregnant women are having experiences where they fear they won't get access to timely and appropriate care if there is a problem?
Sure. Well, so we have the largest telemedicine network in women's and family health. So we have a lot of different providers that our members are speaking to, from OBGYNs to doulas to maternal mental health providers, midwives. We have certainly seen an increase in reproductive anxiety over the last few years since SB 8 was put in place in Texas a few years ago. Mental health providers we're the most booked provider on Maven this past year. And so what we're seeing and hearing from our providers is simply that our patients are turning to telemedicine in states where there may be more restricted access, just to have a private and safe space to have a conversation about what their options are. We see patients who are maybe moving from a state where there isn't restricted access to a state where there is one while pregnant. There's lots of questions around, what do I do? What are my options? And so, I think this uncertainty is not good for women. It's not good for families. And, certainly I think some of the stories that are coming out of hospitals in some of these states around, doctors not being unable and not having the right guidelines or being uncertain on treating things as basic as miscarriage are really worrying our patients and not just our patients, our clients as well. We work with about 2,000 employers in the US and globally and about 20 different health plans, including all 4 national ones. And so, this is when you have such unequitable care across your different offices, if you're running a company, this is a company problem. It's not just a women's health and healthcare problem.
Is telehealth able to fill the gaps? In many cases, it seems like this would be care that a woman might need in person.
It depends, right? I think there's I have to make a plan. What are my options? So certainly we can help with that. Mifepristone and misoprostol are prescribed via telehealth. So that's also an area where telehealth can help. But no, of course, telehealth stops at a certain point. And it's the policies themselves that doctors are following inside of hospitals that are problematic. And I think that, one of our members, as an example, just went in for a routine check, a prenatal visit at 8 weeks, and there was no heartbeat. So she went to one of our providers because the doctor in the state didn't want to do anything yet. They wanted to kind of let it sit for a few weeks, which of course put our member in distress. And so our providers were helping her with her options and trying to figure out what to do. And again, this was just a routine kind of, 1 out of 4, 1 out of 5 pregnancies end in miscarriage. And so that's just an example of the type of situations that our members are in right now. And why, I think it's so important to have a clinic in your pocket to help you navigate it. But, to your point, the only way to really change this is through policy.
And then I wanted to return back to what you were saying about employers. I mean, what role do employers really play in addressing this very uniquely American problem of such a high maternal mortality rate?
So about half of pregnancies, a little under half, are on corporate health plans, right? So employers are actually paying for and designing benefits for about 50% of births in the country. And employers, what they can be doing is pushing on their health plans, pushing on states to enact better policies. And so you've been seeing that a little bit where employers will join a coalition to, for instance, reduce C-section rates in certain states. And so, that's been happening already. So I think, the options employers have is that they can design the benefit, they can design in services like Maven to support and bring more equitable care and bring and fill in some of the gaps, particularly in, postpartum care, maternal mental health, and just give patients that, trustworthy guide and support. But they also can, influence policy, and they can influence just broader care design. So we've even seen some employers band together to push to have more midwives covered. We're seeing employers cover doulas through Maven. or so employers actually are able to do quite a bit here. But again, I think when it comes to Medicaid, which is where a lot of the adverse outcomes are, that is again purely a state thing, and that's, I think, where a lot of the focus should be as we have a national conversation about preventable maternal death, maternal mortality.
And I mean, obviously, and a big part of the conversation is we're seeing big disparities along racial lines. How do we, when we know about this, we've known about it for a while, how do we finally make some traction specifically with those disparities?
I think we need to have just transparent data coming out of hospitals in a lot of these different states. I think that transparency of data, it enables you to kind of design better policy and prove that it's both obviously the right thing to do. Every major medical association believes in access to care and equitable access to care. But also economically, it's the better thing to do. I think, what you're seeing in a lot of these states, if they're not taking care of their pregnancies, they're going to just spend more on pregnancy, which is, I don't think anyone wants that either. And so I think it's just, again, transparency of healthcare data, of outcomes, of economic data. And I think the answer becomes pretty clear, and you can get both sides of the aisle on board with a better system.
Well, Kate, that's all the time we have today. Thank you so much for taking the time today.
Thank you so much for having me.
And now we'll send it over to Paige for our final conversation.
Thanks, Tina. Our final guest today is OBGYN and Chief Medical Advisor for Alloy Women's Health, Dr. Sharon Malone. Hi, Dr. Malone. Thanks for joining us today.
Thank you for having me, Paige.
Of course. I want to start with something that I thought a lot about after my son was born, which is the fact that women have many appointments, sometimes dozens of appointments before they give birth. But afterward, many only have 1 6-week postpartum checkup. And some of my colleagues at Axios have done some reporting that found about 40% of people miss that appointment. And so I want to start with this question, which is, what better systems and practices should be put into place to support postpartum women and birthing people who have just had a baby? What can we do to better support them after that baby is born from a medical sense?
I think it is vitally important that there's more medical follow-up in the immediate postpartum period, because I think that even though we spend a lot of time talking about maternal mortality, what we don't discuss is how many of those unfortunate situations happen after the patient is discharged from the hospital. And yes, we used to have just 1 6-week checkup. Now we've sort of evolved. We have a 2-week check-in for most patients, but it actually needs to be more than that, because now the definition of maternal deaths extends not just for the 6 weeks after delivery, but up to an entire year. So there needs to be many more touch points for the woman after she is delivered than not just before.
I think that makes sense. You mentioned maternal mortality, and we know that Black women and women of color are disproportionately impacted here. And so I'm wondering what practices the medical community is working on and you would like to see put into place to better support Black moms and moms of color, to keep them safe and to support them before and after their babies are born.
Well, I think the most important piece is really education, because it's not as if we don't know what the causes of maternal deaths are for Black women. The top 4 conditions are really cardiovascular ones. So just knowing what the signs, what the warning signs are of preeclampsia, knowing how important it is to monitor your blood pressure, not just before delivery, but afterwards. If you knew these things, and I think if the medical professionals were a little bit more attuned to these findings and not ignoring obvious warning signs, I think that would greatly improve the outcomes. And what we have to realize too is that there is also the front end. And I think that, what we have to be particularly attuned to is the fact that Black women are at more risk for cardiovascular diseases, and these need to be discussed pre-pregnancy, during pregnancy, and afterwards.
Can you talk more about those cardiovascular diseases? What should we be looking out for? What are the signs that people should be aware of? And how should they talk to their doctors about this?
Well, I think the biggest thing is really just hypertension, going into a pregnancy. And one of the things that we have really watched over the years is that the age at first birth is really increasing for all women, and it is higher for Black women. And here is another little interesting tidbit, is that there is also this concept of weathering, which means that for any given age, Black women, even though they may be in a favorable age cohort, they still will do worse than their comparable white counterparts. And that is because these cumulative effects of cardiovascular disease, of chronic stress, of obesity, of even diabetes will also affect and increase a person's risk for impending cardiovascular disease. So this is why the conversation about maternal mortality can't be had in the moment. It needs to be had before pregnancy, during, and after.
Something that's talked about a lot when we're talking about Black maternal mortality and supporting moms in general is working with doulas and midwives in addition to your OBGYN medical team. Sometimes I've sensed that there may be tension between those groups, between the doulas, the midwives, the OBGYNs. I'm wondering if that's a tension that you've ever experienced, and that, how can those groups best work together to support the patient before, during, and after birth?
I think we should look as doulas as really physician extenders. We shouldn't be in competition. They are there to do the things that doctors frequently don't have the time to do. And, having a doula present in the delivery room, and I think the tension comes in when the doulas and the doctors are sort of butting heads about the management of acute care. That is a problem, but I think that whatever doulas can do to support the mothers during labor, and again, doulas are also very helpful for doing those visits and following up once the patient is already home. One thing that we have in today's modern world is that many of us who are having children are having children alone. We're not with our parents, we're not with our families, we're not in that supportive environment that is really there to take care of you. And so that's where I think doulas can be extremely helpful. And midwives, I don't think there's a lot of conflict with midwives because, to be honest with you, midwives are excellent physician extenders because they can be there to support mothers in a way that doctors may or may not have the time or inclination to do. But I think it's always helpful when you're in a situation because when things go bad, they go bad quickly. And my only concern is that for women who are at high risk, that they should really understand that delivering at home or delivering in a birthing center that is not adjacent to a hospital may not be the best idea.
Hmm. You mentioned that more and more people are giving birth without their support systems nearby or without having them. And I think that really plays a big role in postpartum depression, which is being talked about a lot more these days, but it still feels like there aren't as many easily accessible resources for new moms who are experiencing it and a lot of confusion over best practice. So, what do you suggest to patients, to people who are experiencing postpartum depression or supporting someone who's experiencing it?
A lot of times women will be experiencing postpartum depression or the baby blues and not really having, an idea of how important and how serious it can be. And you may not know what is the line between just baby blues and real serious depression. And that's why having a touch point with a professional is important. Many of us are alone. I've had 3 children in a city where I did not have family members. And just being able to have someone to check in on you to say, hey, girl, are you okay? That's important. And to really sort of escalate the situation if it need be. And, there is no shame in that game. I'm telling you, if you are not doing well, you have to really raise your hand and make sure that when you do, there is someone is there to listen and support you.
Something you mentioned earlier, women are having babies later in life. And I know this is another topic you're very well versed on, menopause, perimenopause. I specifically want to ask about perimenopause, which is a time where people can still get pregnant. I'm based in DC. I feel like lots of women wait until later in life to have babies. So maybe this is a time or a question that's very relevant to this area. But I'm wondering, what are some of the dangers to watch out for in having a baby at more of an advanced age? And maybe what are some of the benefits too? Because I assume it's not all bad.
Well, no, it's not all bad. And for many of us, I think you have your children when you're ready to have your children. But I do want women to be aware of the fact that as you get older, your fertility does change. So it's different in your mid 30s than it was in your mid 20s, and it's different when you're in your early 40s. So you just have to be aware of the fertility factor, because that can be another reason why, even for people who want to get pregnant and can't. And the other thing that I think is really important for anyone who is getting pregnant at an advanced age, and when I say advanced age, late 30s, early 40s, is that your risk for these maternal conditions actually goes up with age. The same thing, if I told you most of the events are due to cardiovascular events, well, you're more likely to be hypertensive or overweight or have underlying chronic conditions at 40 than you are at 20. So we have to be especially mindful and careful about women who are in their late 30s, early 40s, not just from, fertility point of view, but how you do throughout the pregnancy. And we spend a lot of time talking about the maternal mortality and the disparities between race, but we also don't spend enough time talking about the fact that maternal mortality increases with age. So for a woman over 40, the statistics are they're about 6 times more likely to experience a maternal mortality than someone who is under 25. So that is just something people should be aware of. Even if you're healthy, just make sure that you are monitored for all of the conditions that we talked about earlier.
Dr. Malone, you've given us a lot of really valuable information. Unfortunately, we'll have to leave it there for today. Thank you so much for joining us.
Thank you for having me.
Of course. Thank you all for joining this afternoon for another virtual conversation that has made us all smarter, faster. For more information or to sign up for the Axios Vitals newsletter, visit axios.com/newsletters. Thank you all for joining, and we'll see you on axios.com.